talk about is BPH, and I would like to draw it and you see what it look like. So BPH is just a prostate. If this is the urethra coming down like that, and then you go into the urethra is within the penile area. Okay, it comes out like that to the opening, and at each side of the urethra coming down is these structures. These are the prostate. So there's two of them on either side. These are the lobes of the prostate. Sometimes this prostate can get bigger. It can get bigger, so they can grow like bigger. And they push on the urethra so that it basically causes some form of obstruction. It's not a true obstruction. It's getting bigger. The cells are growing more than they need to. So that's what we call hyperplasia. This is not cancer. It's not equal to cancer. Okay. There is no something we call dysplastic changes. Dysplastic changes usually lead to cancer. That means the cells look abnormal. These cells are growing bigger, so it's not cancer. It's just they're overgrowing too fast, and they're causing obstruction to the urethra, such that when you have to void, it becomes a problem for this patient. So when you have to void, initiation is always a problem. Okay, and when they initiate, they can weak to continue the flow. So weak continue flow, and that's also a problem. And they'll stop quickly stop early than their usual flow, so they cannot empty properly. Sometimes it takes a lot of energy to do that. And this is the symptoms these patients will undergo. They take them a long time to initiate, but they cannot maintain it, and they will stop early. They cannot empty their bladder completely. So this is what we call BPH, which means benign prostatic hyperplasia. It's not cancer, okay? It's not cancer. So if they ask you such a question, they try to fool you, it's not cancer. They will have, because of this, what is happening, they will have symptoms, they will have this, they will have urgency to go all the time. They will dribbling, the urine will be just dribbling, and they will have frequency, so they'll go multiple times. Those are buzzwords that should come into your head and say, hey, this is what is going on. So what will be your treatment? You got to help with the flow. So treatment means we got to open, okay, the urethra so that you can get bigger. There's two ways of doing it. Okay, there's two ways of tackling this problem. I always a pathophysiology guy. Well, why don't we make this smaller? So make the prostatic portion smaller, or just open the urethra. So open the urethra so that more urine can flow. So that's where we're going to focus our pharmacology. That's all. And you've answered yourself all the pharmacology questions. So first, we need to slow down the hyperplasia. Okay. So we got to slow down the hyperplasia. Luckily, there's enzymes that is involved with the hyperplasia. So we just attack the enzyme. And in the enzyme, there's medication that can attack it. And one of them medication is this Finasteride. So basically, it binds to the enzyme and make it inactive, and it decrease size of the prostate. So this is size of the prostate, basically. So that's what you do. after we bind it, then it will the prostate will decrease in size and help you void. So if you see answer choice, you see this finasteride, that's the alpha, the enzyme that will decrease the prostate size. Another strategy is just basically attack, make the urethra open. Okay, and so these medications specifically can bind to receptors. Okay, there's alpha receptors on the prostate. Okay, after we have bind the enzyme, we can also bind to and destroy alpha receptors in the prostate. And these alpha receptors, so alpha receptors. It's what this medication is going to bind and open the prostate. And one of them is Tamsulosin. We open the prostate, basically open it and allow more urine to flow. So it prevents the contraction. The muscular is so the alpha blockers, they are on the muscle, so they bind to it and inhibit contraction. So inhibit, prevent, or you can say prevent contraction of the smallest muscle. So you open the urethra and more urine can flow. Okay, there's a bunch of them. This is the generic. Okay, in case you see the other ones, this is the only one that has, it doesn't have a zo in it. The other ones are a little bit, you can identify them. Terazosins, okay, Terazosin. Terazosin. So that one you can see are four. One of them is the flow mass. You see, they have the zosin at the end. So the other one do Terazosin. It's just the Tamsulosin that is a little bit different, but he also has the SIN or N in them. Or you can just divide. I usually use the Terazosin, or you can use the OSIN as their last name and then recognize them. But all they do is alpha blocker, open the urethra, allow more urine to flow. And this is a common medication you see in older patients all the time. And it's very common in the United States because of BPH, the older people living better. So this medication has some side effects that they can ask you in the test. So we got to talk about it because it's very important. It's an alpha blocker. It's central acting. Okay. It also has some central acting effect. Most central acting effect medication always causes some drowsiness. Okay. And it causes orthostatic hypotension. You've heard this before multiple times. Anything that causes orthostatic hypotension, well, kind of teaching, you're going to tell the patient what they need to do. Okay. So the teaching, there's teaching associated with this medication. Okay. Take it at night. So they take all these medication at night, otherwise they're going to fall. So there's a 4 rigs. So you teach them about four rigs mitigation. Okay. You got to take care of it. And then it causes orthostatic hypotension. Guess what? They should avoid anything that causes orthostatic hypotension. And one of the key ones, you see it in most older patients, is nitrate, Viagra. So Sildenafil. So you can see how they can have problem. First, they have BPH, they can't pee, and you have to give them to them these alpha blockers. Then what happened? They take Viagra for erectile dysfunction, and they have a bunch of things that can cause orthostatic hypotension, and that became a problem. and they were going to fall. So older patients are always in trouble with this combination of medication. There is specific thing you should avoid with this. They shouldn't take cimetidine or avoid cimetidine. Okay, they should avoid cimetidine. And that's some of the things you should know about. There's report about sexual dysfunction in these medications. So sexual dysfunction in this medication too. And you need to tell them about it. The last thing about orthostatic hypotension, well, you know the teaching, you're going to tell them, change position slowly. And you take this medication at night. But you can see there's the same theme that keep on repeating itself. That's about the prostate. Let's talk about, sometimes we treated them with medication, it's not helpful. So the BPH, so meds not helping. Well, we can make the bladder small, we can make the prostate smaller. So this is we can go back and say, well, if this is the urethra, okay, the penile area and the urethra here, and the prostate is big like that, I can make it smaller. Okay, I can make it smaller. If the enzyme is not helping, finasteride is not helping, I can take a little bit portion of it and remove it. So we can take them to surgery and remove it. The surgery that we do is called TURP. I mean, you see transurethral. So I told you scientists don't know how to name things. So they just describe it. Transurethral, that means we go through here, we go through the urethra. Okay, transurethral. So that's the TU. Okay. Resection. So we're removing it of the prostate. So you go through the urethra, take a little bit of the prostate and come out. There's no incision anywhere. Don't let them trick you. No incision. Everything go through the urethra, through the penile area, and then we remove the problem. Usually they are in the hospital like 1 to 2 to 3 days at least. At the end of the case, the prostate is a highly vascular organ. So it bleeds. So bleeding, your number one priority in patients who have TURP is bleeding precaution. So you're looking for bleeding, okay? You are looking for bleeding. So you want to prevent bleeding as much as possible. That's your job as a nurse. And so that's the main thing. You want to prevent it as much as possible. And what are the things to prevent it? Well, they should not be straining, okay? And then no constipation, so you got to give them stool softener. But this is the caveat. No suppository. Nothing go into the rectum. The rectum, anterior portion of the rectum is where the prostate is. If you put your finger in the rectum and you put a suppository there, you're destroying the prostate bed that has been removed, and that will cause bleeding. So absolutely no suppository. If you want to give them, they want to prevent constipation, let them take the medication by mouth, but no suppository. Absolutely no. 3 times no, because they will trick you with that. Okay, they shouldn't be doing heavy lifting. All these things cause pressure in the pelvis, so then they will bleed. These are the things you teach them not to do, and some of the things you do. What the surgeon will do is to prevent bleeding, to help you. So these patients have 3-way catheter. So they have a catheter. I will draw it for you. So if this is the Foley catheter, so this is the catheter like that. There's a one just for drainage of this going to the drainage bag. Okay. Then there's one that is for irrigation. This is for irrigation. And this one, this is for balloon. So this is the balloon here. And so there's a balloon here. So this is going to sit where the prostate is going to be, used to be, and causes pressure. So it tamponade. The balloon is a tamponade. So it prevents bleeding at the bed. So you can blow the balloon here, and this is to irrigate. So fluid go there, irrigate it, and from all the clots, and it come back. So they have something we call three-way catheter. That means it has 3 ports. That's all. You have to know that there's a three-way catheter used at the end of TURP, and then it's doing it's doing a couple of things. It's irrigating for bleeding. Then tamponade, okay, balloon. So it's just basically preventing the what do they call the pressure. It's applying pressure in the base of where the prostate used to be to prevent further bleeding. Okay, and that is very, very important. The importance of that. Okay, so that is going to prevent further bleeding. Then you irrigating, and then they're getting urine out. So there's things that you have to know specifically about this. What do you expect? So whether next generation questions or right now questions, there's things you have to know what is expected after TURP, expected finding. So expected finding after TURP. So one, the urine is supposed to be pink. Okay, it's pink urine. You see a pink urine in the back here. Secondly, sometimes there can be clot. So you can see some clots, small clots, 1 to 3 days. That's normal. But when you see that, you got to increase irrigation. So you increase the irrigation so that it will prevent clotting the first 1 to 3 days. So you can increase more irrigation to the other port. If you see clot after 3 days, it's not good. Not good. So that means it's bleeding, signs of bleeding. So the doctor needs to know about it. Signs of bleeding. But after 3 days, it's not good. Your priority, number one priority, is to ensure pink urine. Pink urine. So that's all you're checking. You're irrigating and checking pink urine. You monitor the patient. You avoid all the things that we talk about. And then the pressure being provided. This is the same thing of balloon tamponade. What it's doing is pressure at the bed, of the where they did the surgery at. Expected finding again is a bladder. We already did surgery. Every time you operate on the bladder muscle doesn't like that. It go into spasm. So when they give you a patient who had a TURP and he's having spasm, this is okay. You are not being sharp. Okay, if you worry about this, you are not being sharp. If you worry about this clot, yes, that's hemorrhage, shock. So we're looking for pink urine. After 3 days, we have to be sharp about it. Okay, we have to be sharp. Prioritization, you have to be sharp because patient is bleeding. They're not going to tell you the patient is bleeding. They will say 4 days, 5 days, you see large clot in the Foley bag. That is be sharp. Check my distinct prioritization. Be sharp. They're bleeding. And you have to do something. Call the doctor, intervene as much as possible. Pink urine is good. Spasm in the pelvis is fine. Nothing wrong with it. Okay. Nothing wrong with it. There may be a calculation question they can ask you. When I was a resident, we do this. We have to physically do that. So this is the patient. He has the Foley in the bladder. Because everybody is going to make urine. Well, he's going to make his own urine. But you also put in fluid through this, through the irrigation to irrigate the prostatic bed. That fluid should come out. So the total urine in this bag is the one the patient is making and the one you irrigating. So you have to know this from now. Total output is equal to irrigation input plus urine from patient. So the urine you see in the bag is made up of irrigation input, but then the urine from the actual patient. So let me give you an example. If they tell you total output, okay, is 700, and you put in irrigation 400, that means patient P urine output from the actual urine output is 300. That means patient had 300, you irrigate 400, that's why total 400. If you put in 700, the other question they can ask you, if you put in input 300, okay, and you get, let's see, yeah, and you get just 100 output in the bag, something is wrong. You're not getting what you want, what you put in, and even is less. That means the thing is blocked. The patient is bleeding. It's a sign of bleeding. Bleeding will make the folate clot. So if you irrigate with 300 and the output from the bag, total output is 100, that means you've lost 200 and the patient even is not making urine. This is an emergency. You need to let the doctor know right away. If you put in 300 irrigation and the output, total output is 300, then you know the patient is dry. He's not making his own urine, and you can give them more fluid, not irrigation fluid, but more fluid so that they can pee. Just know this calculation can happen. It's easy calculation, but if you have to understand the pathophysiology of the whole thing, what is going on and the output, and that will give you an idea exactly what you need to do. The last thing about this is dangerous, okay? BPH and irrigation. TURP, irrigation, post-op. It can be dangerous. Patient, I mean, it's not easy thing that you got to be, you should, it's not something you should play with. We give them a large amount of fluid through the irrigation catheter to irrigate the prostate bed. And this can lead to hyponatremia because if all the fluid get absorbed into our system, so it's due to absorption of fluid into the blood. So, and that causes severe hyponatremia. And you know hyponatremia is not good. They will have a seizure, okay, they go into coma, okay. They also will have autonomic instability. That means their blood pressure will go up, BP up or down, okay. They will be tachycardic, all this, they will start vomiting, okay, and they will have visual changes. You see some of the symptoms, all is like really bad stuff is happening. All this thing is happening. That is what we call, this is what we call, let me use another color. All this is what we call TURP syndrome. So if they give you a question, somebody at TURP is getting fluid and three-way catheter irrigation, and all of a sudden his blood pressure goes up, down, is having visual changes, you have the nausea, he's vomiting, seizure-like, and you check the potassium lab, and he put sodium is really, really low. This is what we call TURP syndrome. You need to have high level of suspicion, okay? high level of suspicion. Your attendant need to go up and say, oh, this is TURP syndrome. Otherwise, they're going to get sick. So they have like bad symptoms. It's because all the irrigation fluid wash the prostate bed and they get absorbed. So they get like severe fluid and they can even go into pulmonary edema. So I just remember pulmonary edema. So you see, they get fluid overloaded in addition to dilutional hyponatremia. That's bad. You got to do that. And you should know how to treat this. Treatment, you should know by now. If you're taking your test in a few days from now, hyponatremia and somebody who have symptoms with hyponatremia, you should give them 3 to 5, either 3 or 5%, 3 or 5% sodium chloride. Okay, you shouldn't run it fast. Slowly. Okay, if you go too fast, if you correct it too fast, they get central pontine malinosis. Basically, they call it lock-in syndrome. Okay, so you don't want that lock-in syndrome. They cannot do anything. They will be looking at you. You're talking to them, but they cannot move. They cannot do anything. All the motor system is all destroyed from that. So send CPM. I don't know if they ask you that, but it's good to know. If you correct hyponatremia too fast, okay, assuming the sodium is 125, you can go up to like 2 units, 127, slowly, or 128 for like a day, and slowly you increase it up. Don't go all the way to 135. If you do that, you create something, you create so fluids, there will be so much fluid shift, and that will lead to central pontine malinosis, and that's lock-in syndrome. We don't want that. So TURP, you can have TURP syndrome, high level of suspicion to prevent that.